Congress is pushing the One Big Beautiful Bill Act, OBBA. The name sounds cheerful, but inside is a plan to cut roughly $700 billion from Medicaid over the next decade. In the next few minutes, we'll break down the House proposal, the Senate's edits, the real-world winners and losers, and the key dates to watch. Medicaid covers more than 1 in 4 Americans, so any reduction of that scale can reshape who gets care and what it costs. The House draft chases 3 objectives. First, cap the growth rate of federal spending. Second, make most adult enrollees prove they work, study, or volunteer at least 80 hours a month. Third, eliminate the Affordable Care Act bonuses that encouraged late-adopting states to expand Medicaid. If those ideas pass, patients will feel the pinch quickly. Copays could rise to $35 a visit, pushing low-income adults to skip routine checkups. Twice-a-year eligibility checks would catch some fraud, but also drop qualified people who miss paperwork deadlines. Retroactive coverage would shrink to a single month, leaving new members responsible for last month's emergency room bills. Removing expansion incentives may freeze coverage in non-expansion states. One potential upside, banning spread pricing by pharmacy benefit managers, could trim some drug costs, though savings are uncertain. The Senate version keeps the same skeleton but rearranges the organs. Parents with children younger than 15 are exempt from the work rule, and states have until 2028 to show good faith progress. It allows higher copays for non-emergency ER visits. It caps the federal match for emergency Medicaid, shifting more cost to states that treat undocumented patients. Retroactive coverage becomes 1 month for expansion adults and 2 months for everyone else, a 2-tier system that complicates administration. Money mechanics diverge further. The House blocks new provider tax loopholes. The Senate squeezes an existing loophole by 0.5 percentage point each year until 2031. Hospitals that rely on that revenue, especially in rural areas, will feel the squeeze. For state innovation waivers, the Senate hands budget neutrality certification from the Health and Human Services Secretary to the CMS Chief Actuary, betting that technocrats will be tougher than political appointees. Other differences matter in the margins. The House delays disproportionate share hospital cuts until 2028. The Senate stays silent. Both versions bar Medicaid funds from abortion-related providers, but the Senate lowers the revenue threshold from $1 million to $800,000, widening the restriction. Only the House forces states to keep out-of-state pediatric specialists in network. Who wins and who loses? Fiscal hawks tally a big victory on paper. Drug purchasers may gain if the spread pricing ban survives. On the losing side are rural hospitals squeezed by the provider tax phase-down, expansion states losing bonus funds, and patients who cannot cover higher copays or navigate tighter paperwork rules. The timeline also differs. Copay and eligibility changes would start in 2027 under the House text, while the Senate pushes most shifts to 2028, giving state agencies an extra year to rebuild eligibility systems and train staff. Both bills instruct the Centers for Medicare and Medicaid Services to issue implementing guidance within 180 days, so the actual impact will depend on how regulators translate broad directives into step-by-step rules. Nothing is final. Reconciliation rules mean the Senate parliamentarian can strike any provision that fails budget tests, and party leaders cannot afford defections. Expect late-night edits and intense lobbying from every side. Stay tuned for the updated Congressional Budget Office score. Fresh numbers can reshuffle priorities overnight. Until then, every lobbyist in town is counting votes and drafting amendments. If Medicaid influences your health, your hospital, or your state budget, this is the moment to read the fine print and speak up before these cuts move from draft to reality.